Okay, guys, this is the last chapter of the term, chapter 16, the last portion of the endocrine system, and what we're going to do is take a tour of some of the major endocrine glands and describe their functions. So the thyroid gland sits just in front of the trachea. There's two lateral lobes that are connected by a narrow area known as the isthmus. You can see it right here. And it's made up of follicles that produce the glycoprotein thyroglobulin, which is a colloid that combines with thyroxine and triiodothyronine in order to serve as a storage area for these two hormones. It fills the lumen of the follicles and serves as also a precursor of thyroid hormone. It's stored there basically as a polymer, and when the thyroid gland is called on to secrete these hormones, it cleaves the monomers off of the polymer stored in the colloid and releases it directly into the bloodstream. And it has to be carried there by plasma proteins that effectively bind to the T3 and T4 so that it can dissolve efficiently in blood plasma and be carried to its target tissues. Parafollicular cells produce the hormone calcitonin, which is responsible primarily for lowering blood calcium levels. It acts as an antagonist to parathyroid hormone, which is produced obviously by the parathyroid glands. And you can see here the location of the thyroid gland and a look at its histology. These are the areas of colloid. This is extracellular material, and you can see the parafollicular cells, okay, which produce the calcitonin. Note them here and here, and you can also see the follicular cells which surround the colloid. Okay, so the parafollicular cells primarily between the follicles and the follicular cells surrounding the follicles proper. And what is the thyroid hormone's mode of action? It basically serves to raise your basal metabolic rate. Thyroid hormone is actually two related compounds, T4, known as thyroxine, which has two tyrosine molecules bound to 4 iodine atoms, and T3, which has two tyrosines bound to 3 iodine atoms, and is actually the more potent of the two hormones. It affects virtually every cell in the body. It is a major booster of metabolism in that it increases the metabolic rate and the rate of heat production. So it has a calorogenic effect. It tends to raise body temperature. It also regulates tissue growth and development. It's important in the formation of the skeletal and the nervous system in utero, and if we have a lack of thyroid hormone during this period of time, it can result in a condition known as cretinism in the newborn, where the individual has skeletal malformations and also cognitive deficits. It's also important in maintaining our reproductive capability, and it helps maintain our blood pressure as well. And here you can see how thyroid hormone is produced. It's unusual in that it's a lipophilic hormone, meaning it tends to dissolve more easily in nonpolar substances than polar ones. The thyroid gland stores the hormone extracellularly. The thyroglobulin is synthesized and discharged into the follicle lumen. The iodines are actively taken into the cell and released into the lumen and converted there into iodine as a diatomic molecule, and this is an oxidation reaction whereby this occurs. The iodine attaches to tyrosine, and this is mediated by a peroxidase enzyme, and the iodinated tyrosines then link together to form T3 and T4. The colloid is then endocytosed, and a vesicle is combined with a lysosome, which then breaks apart the colloid. The T3 and T4 are then cleaved, and they diffuse directly into the bloodstream. And so you can see here, this is sort of a zoom up of what we're looking at here. This is the colloid in the follicle. These are the follicular cells, and what you're looking at here is the actual breakdown and release of T3 and T4 following this pathway, and the synthesis of T3 and T4 making use of both the rough and smooth ER and the Golgi, and eventually creating now this polymer of hormonal precursor that gets stored in the colloid until it's needed. T4 and T3 are transported by thyroxine-binding globulins. The reason for this, again, is that T4 and T3 are lipophilic, meaning they don't dissolve well in water. They both bind to target receptors, but T3 is 10 times more active than T4. Peripheral tissues then convert the internalized T4 to T3, and this results now in an increase in the cell's ability to oxidize nutrients and to engage in biosynthesis. Negative feedback regulation of thyroid hormone release is shown in the diagram you're looking at now. Rising levels of thyroid hormone provide negative feedback inhibition on the release of thyroid stimulating hormone, which comes from the anterior pituitary, and this in turn reduces the secretion of T3 and T4 by the thyroid. Hypothalamic thyrotropin releasing hormone can overcome this negative feedback during pregnancy or during exposure to extremely cold temperatures. But again, you can see the importance of negative feedback here. If the target cells are continuously bombarded with thyroxine and T3, their metabolic rate will begin to climb and climb and climb in an unregulated fashion. This will have all kinds of negative effects throughout the body. What you see here is that the feedback mechanism that inhibits the production of T3 and T4 is, in fact, the rising blood serum levels of T3 and T4 that inhibit both the anterior pituitary and the hypothalamus. So you get a double shot of feedback inhibition that ultimately inhibits the production of T3 and T4 from the thyroid. Now, occasionally what can happen is that we can have a dysregulation of the thyroid gland. If we see an underactive thyroid in adults, we experience a condition known as myxedema. This can result in a goiter if it's due to lack of iodine in the diet. These individuals tend to be rather heavy. They're not very tolerant of cold temperatures, and their basal metabolic rates tend to be low. Hyposecretion in infants results in cretinism. This is manifested as musculoskeletal defects, but also, more importantly, problems in the formation of the nervous system, primarily cognitive deficit, basically low IQ. Hypersecretion results in an elevated level of thyroxine, and BMR tends to go up. These individuals tend to be thin. They tend to suffer from a condition known as exophthalmia. You can see that condition here. Their tolerance for high temperatures is relatively low. They tend to be rather thin, and they don't have a lot of fat stores in their body because their BMR is so high. Here you can see an example of goiter. Okay, this would be an example of a thyroid gland hyposecretion. You can see the swelling of the thyroid gland right in front of the trach. Oddly enough, both hypo and hyperactive thyroid result in goiter for different reasons. Hyperactive thyroid tends towards goiter because of hypertrophy. Hypoactive thyroid tends towards goiter because of the increased amount of colloid and adipose tissue in the gland. Calcitonin is also produced by the thyroid, and it's made by the parafollicular cells, known as the C cells. It says here no physiological role in humans. It is an antagonist to parathyroid hormone, so this helps regulate blood calcium levels. At higher than normal doses, it inhibits osteoclast activity and the release of calcium from bone matrix. It stimulates calcium uptake and incorporation into bone matrix. So this tends to make the bones become denser and stronger. And here you can see the parathyroid glands on the back of the thyroid. They release the hormone parathyroid hormone, which has the effect of demineralizing bone and raising blood calcium. There are 4 to 8 tiny glands embedded on the posterior aspect of the thyroid. You're looking at the back here of the esophagus and the trach cut away so that you can see the parathyroid glands here, and of course they're embedded in the thyroid tissue. They contain oxapil cells whose function we're not sure of, but also parathyroid cells that secrete parathyroid hormone. It's the most important hormone in calcium homeostasis, and it acts along with calcitonin to help regulate levels of blood calcium. Among its many functions, PTH stimulates osteoclasts to digest bone matrix and release calcium into the blood. It enhances reabsorption of calcium and secretion of phosphate by the kidneys, and it promotes activation of vitamin D by the kidneys while increasing the absorption of calcium by the intestinal mucosa. There is a negative feedback control. Rising blood calcium levels tend to inhibit parathyroid hormone release. Now, there are some homeostatic imbalances of parathyroid hormone that are very dangerous and life-threatening. Hyperparathyroidism can be due to tumor growths on the organ producing an overabundance of parathyroid hormone, which causes the skeletal system to demineralize prematurely. This elevated calcium level will suppress the nervous system and contribute to the formation of renal calculi, also commonly known as kidney stones. While hypoparathyroidism following trauma to the gland or removal or lack of dietary magnesium results in tetany, respiratory paralysis, and death. So you have to remember that calcium isn't simply a structural component of mineralized bone, it's also vital in muscle contraction and nerve transmission. And so if we have a major dysregulation of calcium blood levels, then we're going to have extremely bad consequences for the human machine in total. The adrenal glands are a pair of pyramid-shaped organs that sit on top of each kidney. And there are actually two glands in one, an inner medulla, which is actually a modified secondary neuron in the sympathetic nervous system, which releases adrenaline directly into the bloodstream when the sympathetic division of the autonomic nervous system is active, and the adrenal cortex, which contains 3 layers of glandular tissue that synthesize and secrete corticosteroid hormones. These are, again, another class of lipid-soluble hormones that have a variety of different modes of action. What you're looking at here is just a cross-section through the adrenal cortex and medulla. You can see the capsule at the most superficial aspect, the zona glomerulosa, the fasciculata reticularis, and there you can see the medulla, which contain the chromaffin cells that actually release the adrenaline directly into the bloodstream. The zona glomerulosa is primarily responsible for the production of mineralocorticoids, and the one you're probably most familiar with is aldosterone, which is your hormone that regulates salt retention. Okay, so it acts on the kidney tubules in order to cause the tubules to reabsorb sodium and secrete potassium. The fasciculata produces glucocorticoids. The major glucocorticoid is cortisol, which has the effect of raising blood glucose levels. And finally, the reticularis produces androgens, which are basically testosterone mimics and control the manifestation of secondary sex characteristics. You can see in this panel here on the right the actual histological section through the organ. So you can pick up here the capsule and the glomerulosa, the reticularis, the fasciculata and the reticularis, and then down here the medulla. Notice that they have distinct morphological differences. They're also functionally different in terms of the hormones that they produce. The origins of the cortical portion of the adrenal gland are completely different than the origins of the medulla. The medulla is basically an outgrowth of the nervous system, while the cortex comes from a completely different embryological origin. They just happen to be bound together as a single gland. Mineralocorticoids regulate electrolytes, primarily sodium and potassium, in the extracellular fluid. They're important in the electrolyte balance of sodium and potassium. They affect extracellular fluid volume, blood volume and pressure, and the levels of other ions. Remember that electrolytes are important because, among other things, they maintain membrane potential, which is vital in excitable tissues such as muscle and nerve. The importance of potassium is that it sets the resting membrane potential of cells. Aldosterone is the most important mineralocorticoid. It stimulates sodium reabsorption and water retention by the kidneys while simultaneously eliminating potassium. Its release is triggered by decreasing blood volume and pressure and rising levels of potassium in the blood. Now, one of the things that we need to be aware of is something called the renin-angiotensin-aldosterone system that acts to regulate our blood volume and blood pressure. It responds to decreased blood pressure by stimulating the kidneys to release renin, which triggers the formation of angiotensin II, which is a potent vasoconstrictor and stimulator of aldosterone release. It also promotes thirst. Plasma concentrations of potassium also trigger its release. Increased potassium directly influences the zona glomerulosa to release aldosterone, and this will increase the potassium secretion in the kidneys. And ACTH causes small increases of aldosterone during stress. Atrial natriuretic peptide blocks renin and aldosterone secretion and decreases blood pressure. It's okay, you can come on in. Okay, as with any endocrine organ, you can have imbalances, and homeostatic imbalances of aldosterone can be either due to hyper or hyposecretion. Hypersecretion is often due to tumor formation on the organ and results in hypertension and edema because of excessive sodium retention, and that in turn leads to excessive water retention. Excretion of potassium can also lead to abnormal functions of neuron and muscle. Remember that potassium and sodium are critical in maintaining membrane potential. Glucocorticoids help keep blood glucose levels relatively constant, and they maintain blood pressure by increasing the action of vasoconstrictors. The most important glucocorticoid is cortisol. It's also known as hydrocortisone, and other glucocorticoids include cortisone and corticosterone. What do? Well, they're released in response to adrenocorticotropic hormone, which of course comes from the anterior pituitary, and it controls patterns of eating, activity, and stress. Its most important metabolic effect is gluconeogenesis, so it spurs the production of novel glucose from non-carbohydrate precursors, primarily fats and proteins. This causes blood glucose to rise, and fatty acid and amino acids rise in the blood serum as well. It saves glucose for the brain because this is the only fuel that the brain can metabolize, and it enhances vasoconstriction, resulting in a rise in blood pressure to quickly distribute nutrients to the cells. Hypersecretion is often the result of Cushing's disease. This depresses cartilage and bone formation, and it inhibits inflammation. It suppresses the immune system, and it disrupts cardiovascular, neural, and gastrointestinal function. Hyposecretion causes a condition, or often results from a condition known as Addison's disease. It also involves deficits in mineralocorticoids. We see a decrease in glucose and sodium levels in the blood, and we also observe weight loss, severe dehydration, and hypotension. So you can see here in the inset a panel showing a patient before and after the onset of Cushing's disease, and what you want to notice here is that we see deposition of body fat, the buffalo hump indicated by the white arrow. We also see an increase in weight. We see a reduction in overall metabolism, and again, we have to treat this by supplying the missing hormone using either an oral or an injectable. Gonadotropins are the weakest androgens. They're converted to testosterone in tissue cells. Some are converted to estrogen. So this is one of the two areas of the body that secrete the sex hormones, testosterone being the primary male sex hormone, and estrogen and progesterone being the primary female sex hormone. They can contribute to the onset of puberty, the appearance of secondary sex characteristics, libido in women, and estrogens in postmenopausal women. Hypersecretion can result in androgenital syndrome, which is masculinization. This isn't noticeable in males, but in females and prepubertal males, what we see are reproductive organs that mature early, and secondary sex characteristics such as axial and body hair, an increase in lean muscle mass and hematocrit and bone density, all of which emerge before the advent of puberty. In females, we see the production of axial and body hair, a masculine distribution of body hair and fat, and the clitoris will enlarge to resemble a small penis. The adrenal medulla is the core of the adrenal gland, and the chromaffin cells synthesize epinephrine and norepinephrine as hormones directly into the bloodstream under the influence of the sympathetic division of the autonomic nervous system. Epinephrine and norepinephrine promote vasoconstriction, an increased heart rate, an increased blood glucose level. It also diverts blood to the brain, the heart, and the skeletal muscle, and we also see an increase in heart rate, respiratory rate, and blood pressure. These responses tend to be brief. Epinephrine stimulates metabolic activity such as bronchodilation and blood flow to skeletal muscle in the heart, and norepinephrine influences peripheral vasoconstriction and blood pressure. The bottom line is that this augments what we know as the fight or flight response, which is the role of the sympathetic division of the autonomic nervous system, and this is to prepare the body for an encounter with danger in order to prepare you either to fight or to flee. And as a result, it makes sense that the blood glucose levels rise, the blood oxygen levels rise, the blood pressure goes up, the blood glucose levels go up. All of the changes that we've noted here contribute to each of these phenomena. In addition, the glomerular filtration rate drops, and the reason for that is to increase blood volume and, as a result, blood pressure. Hypersecretion in the medulla results in hyperglycemia, increased BMR, a rapid heart rate, palpitations, hypertension, nervousness, and sweating, while hyposecretion is generally not problematic. Adrenal catecholamines are not essential to life. We can get by without them. And here you're just looking at the stress response and how it coordinates the activity of the sympathetic division of the autonomic nervous system, as well as the secretion of adrenaline directly into the bloodstream. So you can see here the production of catecholamines from the adrenal medulla, stimulated by nerve impulses that go via the descending tracts of the spinal cord out the ventral root and ultimately to the organ, and causes all the changes that we noted earlier. Here you can see what happens in prolonged stress. We end up via the anterior pituitary stimulating the production of adrenal corticoids, primarily cortisol and mineralocorticoids, which have the effect of dysregulating blood sugar and blood pressure, as well as blood volume, and also suppressing the immune system. The stress response isn't meant to be something that goes on for a long period of time. It's meant to be momentary, and what you're looking at here with these effects are what happens if we drag this stress period out longer than is healthy for the body. The pineal gland hangs from the roof of the third ventricle and produces a hormone known as melatonin, which is derived from serotonin. Pianocytes secrete this hormone. We think that it affects the timing of sexual maturation and puberty, although the research for that is controversial, but we do think that there is a strong link with our circadian rhythm, basically the syncing up of our body's activity levels with the cycling of day and night. It also controls physiological processes that show rhythmic variations. These include changes in body temperature, in sleep patterns, and in appetite. It also aids with the production of antioxidant and detoxification molecules in cells in order to preserve them so that they don't prematurely die. The pancreas is an organ that's both an exocrine and an endocrine organ. It's a triangular gland that's located between the duodenum and the spleen and lies behind the stomach. The acinar cells produce the exocrine secretions, which include enzymes that help break down the food we eat chemically so that we can absorb it into the bloodstream. And pancreatic islet cells that contain endocrine cells, alpha and beta cells here in the islets, in these highly vascularized regions of the organ. The alpha cells produce glucagon, which has the effect of elevating blood glucose. The beta cells produce insulin, which is a hypoglycemic hormone, and it lowers blood glucose by alerting cells to the presence of sugar in the blood so that they can take it up and use it for energy. The acinar cells you can see surrounding the islets here, and they have a very different morphology, and they produce entirely different products. The difference between an exocrine and endocrine gland, remember that an exocrine gland has a duct, basically a hose through which its products are released either into a lumen or onto a surface, whereas an endocrine gland secretes its products directly into the bloodstream. The major target for glucagon is the liver. It causes blood glucose levels to rise. It promotes glycogenolysis, which is the breakdown of glycogen to release glucose into the blood, and gluconeogenesis, which is the production of glucose from non-carbohydrate precursors, which also serves to elevate blood glucose. The result of this is that we increase blood glucose levels between meals when we need energy, and this helps to serve primarily tissues that can only use glucose as an energy source, the nervous system being the primary consideration here, but also the energy needs of other tissues. Insulin lowers blood glucose levels and enhances the membrane transport of glucose into fat and muscle. It inhibits glycogenolysis and gluconeogenesis, and it participates in neuronal development as well as learning and memory. It's not needed for glucose uptake in the liver, the kidney, or the brain. What does it do when it acts on cells? Well, it promotes a tyrosine kinase enzyme-linked receptor that's on the membrane. This cascade results in increased glucose uptake, which causes enzymes to catalyze the oxidation of glucose for ATP production and polymerize glucose to form glycogen to store that in the liver and in muscle, as well as converting glucose into fat, primarily in adipose tissue. What you're looking at here are some of the factors that influence insulin release. Elevated blood glucose levels are the primary stimulus here. These rising levels of amino acids and fatty acids promote the release of insulin from the pancreas, and what this does is promotes the uptake of sugar from the bloodstream and the conversion either into glycogen or into fat. Okay, so you can see here what's happening on this end of the spectrum. The release of acetylcholine by parasympathetic nerve fibers is also a primary trigger here. Hormones glucagon, epinephrine, growth hormone, thyroxine, as well as glucocorticoids all tend to elevate blood glucose levels, while insulin tends to drop them. Somatostatin is produced in response to influence from the sympathetic nervous system, and it tends to decrease blood glucose levels and serve as an antagonist to somatotropin. So you can see here what's happening as blood glucose levels rise, insulin is secreted, tissue cells store the fuel or use it for energy, and blood glucose levels begin to fall. If they fall below our balance range, about 90 milligrams per 100 mils, the pancreas will secrete glucagon. This will act on the liver to promote glycogenolysis and gluconeogenesis. This promotes an elevation in blood glucose levels, and we return back to our normal levels. So again, homeostasis maintained here by the antagonistic relationship between these two hormones. And again, it's not to say that when one hormone is secreted, the other is completely absent. It's just that one or the other may predominate depending on the conditions on the ground at that moment. Diabetes mellitus is due to a variety of causes. Hyposecretion is what we call type 1 or juvenile onset diabetes, and it results from the death of beta islet cells in the pancreas, primarily due to an autoimmune attack on those tissues. Um, Type 2 diabetes mellitus is due primarily to inactivity and increased caloric intake, and the result of this ultimately is to increase your body fat stores, but also to become insensitive to your own insulin. The result is the same in either case. Blood glucose levels tend to rise and become difficult to modulate. The treatment for type 1 is to use insulin. The treatment for type 2 is to either increase the sensitivity to insulin using injectable or oral meds, or in combination with that, to increase activity levels and decrease calorie intake. Blood glucose levels in these individuals tend to remain high. This leads to nausea and higher blood glucose levels. Glycosuria results. This is glucose that's spilled into the urine, which also results in polyuria because of the osmotic effect of the glucose. Fats, as a result, get used for fuel, and as a result, they're not completely oxidized. And this results in the production of byproducts known as ketone bodies that results in a condition known as ketoacidosis and can lead to ketonuria, which are ketones in the urine. This, in the long run, is bad because it can result in hyperpnea. This can disrupt heart activity and oxygen transport. It can result in depression of the nervous system, and it can lead to coma and death. Now, there's another type of diabetes which is called gestational, and that results in pregnant mothers due to the fact that the placenta intercepts the insulin that's produced by the pancreas before it gets to its target tissue. As a result, during the third trimester, the mother's blood glucose levels begin to rise, and she begins to show some of the early indicators of diabetes. It ends when the baby's born because now the placenta is absent and the insulin can now go back to hitting its target cells and regulating blood glucose the way it was meant. Hyperinsulinism is a result of excessive insulin secretion. This causes hypoglycemia, which results in low blood glucose, can lead to anxiety, nervousness, and disorientation, as well as unconsciousness, and can even lead to death in extreme circumstances. We treat this by sugar ingestion. The ovaries and the placenta are important in the reproductive system in the female. The gonads, which in the female are the ovaries, produce steroid sex hormones, as does the adrenal cortex. The ovaries produce estrogen and progesterone. Estrogen promotes the maturation of reproductive organs and the appearance of secondary sex characteristics, and progesterone causes breast development and cyclic changes in the uterine mucosa. It is part of what triggers the menstrual cycle. The placenta secretes estrogens, progesterone, and human chorionic gonadotrophin, and these hormones are important in the uterine and ovarian cycles. Essentially, the way that this works is that when an egg is ovulated from the ovary, the follicle cells stay behind and become a structure known as the corpus luteum, which begins secreting estrogen and prepares the endometrium for the implantation of the fertilized egg known as the zygote, which by the time it reaches the uterus will have become a hollow ball of cells known as a blastocyst. And what happens once the conceptus implants is that a chorion is established, and it produces HCG, human chorionic gonadotrophin, which feeds back via the bloodstream to the corpus luteum to help it continue to secrete estrogens and progesterone in order to maintain the endometrial lining so that the pregnancy can go to term. The dominant hormone prior to ovulation coming from the follicle is estrogen. The dominant hormone after ovulation coming from the corpus luteum is progesterone. And progesterone promotes endometrial thickening due to an increase in cell size, while estrogen produces endometrial thickening due to an increase in cell number. Okay, so there's two phases. There's the the follicular phase, which is dominated by estrogen, which comes prior to ovulation, and the secretory phase, which comes after ovulation, which is dominated by progesterone. The testes produce testosterone, which initiates the maturation of male reproductive organs and causes the appearance of male secondary sex characteristics and libido. It's important for normal sperm production and maintains the reproductive organs in a functional state. Other hormone-producing structures include adipose tissue. Leptin is thought to control appetite, and it stimulates an increased expenditure of energy. Resistin is an insulin antagonist, so it acts to counter the effects of glucose uptake and glycogen and fat storage. Adenopectin or adiponectin enhances the sensitivity to insulin. There are also enteroendocrine cells in the GI tract, such as gastrin, which stimulates the release of hydrochloric acid from the gastric mucosa in the stomach, and secretin, which stimulates the liver and the pancreas to produce pancreatic juice and bile in equal amounts. Cholecystokinin stimulates the pancreas, the gallbladder, and the hepatopancreatic sphincter, and is the trigger for the release of pancreatic juice and bile into the duodenum just prior to the chyme entering it through the pylorus of the stomach, so that we can engage in the next phase of the chemical breakdown of food through the digestive tract. And serotonin acts as a paracrine signaling hormone. Paracrine hormones are different in that they don't act via the bloodstream at distant targets. Instead, they act on nearby cells through diffusion. The heart produces atrial natriuretic peptide, which decreases blood sodium concentration and as a result decreases blood pressure and volume, while the kidneys produce erythropoietin, which promotes the production of red blood cells and increases the hematocrit, while renin initiates the renin-angiotensin aldosterone mechanism. Remember that renin is a potent vasoconstrictor and promoter of thirst, and it tends to increase blood volume and blood pressure. As a result, it is a very important homeostatic control on the function of the cardiovascular system. The skeleton produces osteocalcin, which prods the pancreas to secrete more insulin. This restricts fat storage. It improves glucose handling, reduces total body fat. It's activated by insulin. Low levels of osteocalcin result in type 2 diabetes. Perhaps by increasing the levels, there may be a treatment for this particular blood glucose condition. And the skin produces cholecalciferol, which is a vitamin D precursor, and it requires that A, you consume vitamin D in your diet, but B, you expose your skin to the UV rays of the sun in order to produce this active component of vitamin D. The thymus is the area of T cell maturation. Remember that T cells are one of our disease fighters. It tends to be rather large in infants and children. It shrinks as we age, and it produces the hormones thymulin, thymopoietin, and thymosins. These may be involved in the normal development of T lymphocytes in the immune response, and they're classified as hormones, but they act via a paracrine route. The lymphocytes are important because these are our specific defenses against disease, and one of the things that we're going to learn about when we talk about the immune and the lymphatic system is that the body has two sets of defenses against invasion by pathogen. Your nonspecific defenses use an identical chemical attack regardless of the identity of the incoming pathogen in order to fight the disease. But in the event that the pathogens get past these chemical attacks and these physical barriers, the immune system via the lymphocytes, the T and the B lymphocytes, will act to generate a population of cells that can specifically knock out that pathogen using magic bullets called antibodies that will specifically attack only that particular strain of pathogen and mark it for destruction, or through cell-mediated immunity where the T cells actually show up at the site of infection or disease, for instance, cancer cells or cells infected with viral or bacterial pathogens, and destroys them by compromising the membrane integrity of the diseased tissue or by secreting chemical compounds that cause those cells to commit suicide in a process known as apoptosis. Okay, that brings us to the end of this chapter. There is an endocrine video that I will show following this presentation, so stay tuned. You'll look at the mode of action of thyroid hormone and steroid hormone and peptide and amino acid derivative hormones, those that dissolve easily in water. And we'll have also a general discussion of, of the immune system. So I'll see everybody in class.
The endocrine system is composed of ductless glands that secrete hormones, chemical messengers that control homeostasis. The hypothalamus controls the secretions of the pituitary. Nerve cells in the hypothalamus send releasing hormones to anterior pituitary to release hormones. Hormones are growth hormone, TSH, ACTH, MSH, FSH, LH, and prolactin. Hormones produced by the hypothalamus are stored in the posterior lobe of the pituitary. Hormones are ADH, increases the reabsorption of water, and oxytocin, contracts the pregnant uterus. Pituitary gland is called the master gland because it controls the function of other endocrine glands. T3 and T4 regulates metabolism of nutrients for normal growth and matures the nervous system. Calcitonin lowers blood calcium and phosphates. Parathormone raises the blood calcium to normal levels. Medulla secretes adrenaline and norepinephrine that prepare the body for stressful situations. Cortex secretes aldosterone, regulates sodium reabsorption and potassium excretion in the kidney. Cortisol reduces inflammation. Androgens stimulate male sex characteristics. Testes produce testosterone. Ovaries produce estrogen and progesterone, hormones necessary for development of reproductive systems and secondary sex characteristics. Thymosin is necessary for the development of T lymphocytes. Melatonin regulates the body wake and sleep cycles and inhibits the function of the reproductive system. Serotonin acts as a neurotransmitter and vasoconstrictor. Islets of Langerhans produce insulin and glucagon that regulate the blood glucose level essential for energy.
Secretory products of endocrine cells are called hormones. Secretory vesicles release the hormones into the extracellular fluid via the process of exocytosis. The hormones are transferred to other cells in the body. These are called target cells. Specific receptors in the plasma membranes of the target cells permit the hormones to bind to the cells. When hormones bind to their specific receptors, they provide a signal to the target cell to alter its activity. Endocrine cells must be precisely regulated because just a small amount of hormone can produce a large effect. Endocrine cells respond to signal molecules. An activation or inhibition of the cell's activity results. Signal molecules can come from three sources. These sources of regulation include neural regulation, hormonal regulation, and humoral regulation. Signal molecules from nerve cells directly regulate some endocrine cells, such as those in the adrenal medulla. Nerve cell processes form junctions with endocrine cells. When a nerve impulse reaches the end of the nerve cell process, neurotransmitters are released. These neurotransmitters serve as signal molecules to activate the endocrine cell. Hormones secreted from one endocrine cell can regulate the activity of another endocrine cell. Hormones that target endocrine cells are called tropic hormones. Here, the hormone ACTH is secreted from the anterior pituitary and travels in the blood towards the adrenal cortex, its target cell. The hormones bind to the target endocrine cells and control their activity. Some endocrine cells are regulated by changes in the blood concentration of certain ions or nutrients. Certain conditions in the body may result in increases or decreases in the blood concentration of certain ions like potassium or nutrients like glucose. Endocrine cell activity changes in response to the changing levels of these ions and nutrients. Target cells will be Hormones secreted from one endocrine cell can regulate the activity of another endocrine cell. Hormones that target endocrine cells are called tropic hormones. Here, the hormone ACTH is secreted from the anterior pituitary and travels in the blood towards the adrenal cortex, its target cell. The hormones bind to the target endocrine cells and control their activity. Overproduction of hormones will result in overstimulation of target cells. In this situation, high hormone levels will cause target cells to produce a smaller number of receptors. This is called downregulation. Target cells that are downregulated are less sensitive to the signaling hormone. The cellular interactions between signal molecules and endocrine cells are a part of a much broader systemic regulation mechanism called feedback regulation. Feedback regulation is one of the main mechanisms for the regulation of hormone secretion. The components of a hormone feedback loop are the stimulus, change in condition, endocrine cell, signaling hormone, target cell, the target cell's action, response. The feedback occurs when the hormonal response from the target cell affects the endocrine cells that initially secreted the hormones. Depending on the effect of the hormone on the initial endocrine cells, a feedback mechanism can be either positive or negative. A positive feedback mechanism is one where the response stimulates the endocrine cell and causes it to be more active. The hormone oxytocin is produced in the hypothalamus and released in the posterior pituitary in response to the stretching of the uterine cervix during labor. In its turn, oxytocin stimulates uterine contractions that forces the fetus into the cervix. As the cervix continues to stretch, the release of oxytocin continues to increase until the cycle is stopped with the birth of the baby. A negative feedback mechanism is one where the response reduces or eliminates the changes caused by a stimulus. Glucagon is the hormone produced in the pancreas in response to decreasing levels of glucose in the blood. Glucagon stimulates liver cells to convert glycogen into glucose and release it into the blood. As a result, blood glucose levels begin to rise. As the increase in blood glucose level approaches a normal homeostatic condition, glucagon production is inhibited.